Thank you very much. Okay, so thank you very much to the organisers for inviting me to talk to you tonight, and a pleasure to be with you all. And I'm going to talk about what we learnt from the paediatric DOAC trials. I have no financial disclosures to make. I don't receive any consulting fees or speakers fees. I have some intellectual conflicts in that I have been on the steering committees for some of the trials and have enrolled patients both with rivaroxaban and apixaban. And while my research team receives some support from some industry sources, none of those are relevant to what I'm talking about tonight. So why do we need pediatric DOAC data on top of the adult DOAC data? Because everything about pediatrics is different. The epidemiology is different. The levels of evidence that we have are different. The physiology is different. The diagnostic strategies are different. The pharmacology, the way we interpret the monitoring tests, and even to the outcomes of interest are different. Again, in adult medicine, for the most part, when we're treating things, we're trying to return it to its former state so that the adult becomes well again. Whereas in children, we are not only looking to restore health, we are looking to enable potential for the next 80 years, which is a very different construct to how we treat adults. So when we think about all of those differences, the first one that often comes to mind is developmental hemostasis, a concept that was really pioneered by Maureen Andrew with her 3 landmark publications in Blood in the late 80s and the early 90s. Since then, many other people have demonstrated that developmental hemostasis is real and physiologically important, both in terms of the way that we diagnose coagulation abnormalities in children in the clinical laboratory, but also in the way that we interpret monitoring tests for anticoagulants in children. But I think in specific regards to the DOACs, an important point to remember is that most of the previous work that had been done on developmental hemostasis functioned on the functional levels. This paper from Attard that was published in 2013 was really the first paper that had a good look at the underlying antigenic levels. And although this is a busy slide, I've just highlighted the boxes around factor 2 and factor 10, the targets of some of the DOACs, and you'll see that the antigenic levels of those target proteins change dramatically across the age groups. And so there's a whole lot of other questions around developmental hemostasis, around why and what's its physiological purpose, but I don't subscribe to the notion that the coagulation system in children is immature and it matures into the adult. The coagulation system in the newborn and the child is perfectly adapted to what it needs to be in the newborn and the child. And it changes as it gets older. And one could argue that it deteriorates as you move into adult age, because adults are much more prone to abnormalities of clotting and indeed bleeding than children are. That's borne out by the epidemiology of VTE, which occurs at a far lower frequency than what we see in adults. And the community-based rate of clots in children is very small. However, in hospitalised children, the rates increase to about 100 or 1,000 times what we see in community-based children. And over 90% of those cases have multiple risk factors, and those risk factors are most often iatrogenic. Venous access devices account for a large amount of the thrombosis that we see in children. It's important to understand that for many children, the natural history of thrombosis remains unknown in terms of the different types of thrombosis. From the registry data, it appears we have a direct mortality of around 3%, and the recurrence rate may be around 10 to 15%. But about 16% of children who have VTE will die from their underlying illness, which again highlights the fact that this really is a disease of sick children. When we think about the DOACs and what has come out of the DOAC trials, it's important to understand what was the status of our knowledge of anticoagulation in children prior to the DOAC trials. This is data from one of our systematic reviews that we did when we wrote the American Society of Haematology guidelines for VTE treatment in children in 2018. And what you'll note is that for DVT and PE, in terms of randomized controlled data, the sum total of children that we had randomized controlled data on for low molecular weight heparin was 36. And the total number of children that we had randomized controlled data on who had received vitamin K antagonists was 40. We still had less than 1,000 children on whom we had observational data. If we then move on to CVC-associated clots, it was only in the 20s that we had numbers of from randomized controlled data. And if we talk about cerebral sign of venous thrombosis, we had no randomized controlled data at all prior to the DOAC trials. So when we think about the levels of evidence that the DOAC trials provided that I'm about to present to you now, the first thing to remember is that we now have far more data about the DOACs than we ever had about the agents that we were using before the era of the DOACs. So what are the key areas of learning from the DOAC trials? Well, first is the information about safety and efficacy of certain DOACs in children under specific conditions, and that's what I'm going to focus the rest of the talk on tonight. But as I just intimated, we also learned a lot about the safety and efficacy of the standard of care anticoagulants like the vitamin K antagonists and the low molecular weight heparin, because we actually obtained more randomized controlled data on those agents during the DOAC trials than we had ever had previously. We certainly learned a lot about the methodology for performing anticoagulant in trials, and that's a whole other talk, so I'm really not going to get to that tonight. And we learned a bit about the pros and cons of extrapolating data from adult trials into pediatrics, and I will just briefly mention why that's important. So if we start with the rivaroxaban Einstein Junior program, the largest and the most published of the programs completed to date, what you'll note is that we started this program back in 2009, and the first publications from the program came out in 2019. In fact, we had our first meetings about the program in 2007. This was a 12 or 13-year program to enroll a sum total of 700 children who were exposed to rivaroxaban. So again, it just highlights the difficulty of doing randomized controlled trials in children in this space. A series of trials that culminated in the phase 3 trial, which was a randomized controlled trial where children who had a proven VTE in any site, it could be cerebral sinus thrombosis, pulmonary embolus, deep venous thrombosis of the upper or lower system, renal vein thrombosis, any venous thrombosis. Once they were diagnosed, they needed to receive a heparinoid for between 6 and 9 days, and then subsequently they were randomized to either rivaroxaban or standard of care in a 2-to-1 ratio. So 2 rivaroxaban for every 1 standard of care. At the end of their 3 months, they had repeat radiographic imaging to document what had happened to the clot. And if they only needed 3 months of treatment, they could stop and they were then followed for 30 days, or they could move into an extended period of treatment for 12 months if they needed ongoing treatment. Children who were less than 3 years, who are often, less than 2 years of age, who are often treated for a shorter period of time, could be enrolled into the study with as little as 1 month treatment. The first patient was enrolled in the last quarter of 2014, and the last patient last visit was in Q1 of 2019. So when we look at what we learnt from the study, this shows the PK parameters, and the red bands for the peak, trough, and AUC measurements that you can see. The red bands represent the data that was achieved within the adult studies. And you can see that for older children, we have body weight along the x-axis. Older children needed once daily treatment. However, as they came down on weight, we had to move towards the yellow dots, which was twice daily treatment to keep them in the range. And then as we got down even younger, we needed to move to 3 times a day rivaroxaban. And in the very young babies, there was debate as to whether we needed to move them into 4 times a day or just go with a higher dose at 3 times a day, which was what was chosen on compliance grounds. But you can see even then, the youngest children are starting to actually dip down to the bottom end of the curves. When we then look at the measured PK parameters in terms of the trough, peak and AUC levels, there was no correlation specifically with the reduction in clot burden. So there was no clustering at the lower end of the patients whose clot did not change, and there was no clustering at the upper end of the patients whose clot did normalize or improve. So long as you were in the therapeutic range, then you were doing okay. Similarly, when we look at the bleeding events, there was no clustering with bleeding events at either end of the ranges to suggest that there was a strong dose-dependent rate associated with any bleeding events that were seen in the trial. And the rivaroxaban plasma levels correlated very well with the anti-10A levels in all phases of the trial. So when we look at the pre-specified efficacy and safety outcome data from the Einstein Junior phase 3 randomized trial, we see that in the rivaroxaban arm, 1.2% of children had recurrent VTE versus 3% in the standard of care arm. In terms of what was seen on repeat imaging, 1.5 had recurrent or deep irritation on imaging percent in Riva compared to 3.6% in the standard of care. Mortality, there was only one mortality death in the whole study that was unrelated to anticoagulation. In terms of major bleeding, there were no major bleeds amongst the rivaroxaban cohort and only 2 major bleeds, or 1.2% of patients, amongst the standard of care. And when we look at major or clinically relevant non-major bleeding, 3% in rivaroxaban versus 1.9% in standard of care. If we think about the thrombotic burden in terms of normalization or improved, there was no real difference between the 2 arms of the study, with about 70%, just over 70% either improving or normalizing in the rivaroxaban arm, and about the same in the comparator arm. This graph compares the bleeding and clotting rates in rivaroxaban and the comparator to what was seen in the comparable adult trials. So if you look at the top line of the graph, the recurrent VTE, what you see is that in the blue line, the results of the Einstein Junior program compared to the green line of what was seen in the adult trials. So about the same rates of recurrence with Riva in children as what was seen in the adult trials. Whereas in the comparator, the rates of recurrence were higher in children than what was seen in adults who were treated with standard of care. And when we look at the bleeding, comparing the pediatric data to the adult data, you can see that the on the left with the rivaroxaban, the bleeding rates amongst the children were much lower than what was seen in the adults, and that is true also in the comparator. As I mentioned before, we needed to come down on doses as we came down on weight of the child. So above 30 kilos was treated with once daily, between 12 and 30 kilos with twice daily, and below 12 kilos was treated with 3 times a day. And this was to achieve a plasma exposure that was similar to what was seen in adults who were exposed to 20 milligrams once daily. So the Einstein Junior program has provided us with a large number of publications that have really provided some of the best evidence we have, not only about the use of DOAC or rivaroxaban specifically in children, but also about our previous standards of care, low molecular weight heparin and warfarin. And there are further publications to come from that study. If we now turn our mind to a prophylactic study with rivaroxaban, this was the Universe study. So this study was looking at children whom have post-Fontan and was comparing rivaroxaban to aspirin. So there are two phases to the study. In the first 12 children enrolled were actually just given open label rivaroxaban twice daily to achieve an exposure that was equivalent to a dose of 10 milligrams once a day in adults. So important to understand, in this study, we're targeting about half the levels, plasma levels that were targeted in the Einstein Junior treatment trials. In phase 2 of the study, once those 12 children had been exposed to rivaroxaban and the PK was known, 90 children were randomized in a 2-to-1 mechanism to receive either rivaroxaban or aspirin for 12 months following Fontan therapy. They had to be enrolled within 12 weeks of their Fontan surgery, and in the rivaroxaban arm, the mean date of randomization was 45 days post the Fontan surgery, whereas in the aspirin arm, the mean date was 37 days post the Fontan surgery. Fontans are important for those of you who aren't pediatrically orientated, because it's a definitive palliative procedure of a univentricular heart, and they are one of the groups that lead to the highest rates of thrombosis that we see in our cardiac surgical populations. So here in the study, the 12 patients in Part A who completed, and 10 of them completed treatment. Of those patients who were randomized in Part B of the study, there were 66 who received rivaroxaban, and of whom had one thrombotic event, so a 2% thrombosis rate within the rivaroxaban arm, compared to a 9% event rate of either thrombosis or stroke in the aspirin arm. The dosing regime that was used in Universe was a twice daily dose for all children. This study only enrolled children between 2 and 8 years of age, because that are the ages that most commonly have their Fontan surgery. And so these are the weights that we would normally expect to see a range of across that age group. And as I say, the dosing was BD dosing to achieve the same plasma exposure as what was seen with 10 milligrams a day once daily in adults. What's interesting when we look at the bleeding rates in this study was that the bleeding rates are actually higher in this study, both in the rivaroxaban arm and in the aspirin arm, than were reported in the Einstein Junior study, which was targeting levels that were twice as high in terms of plasma levels. I suspect that this may have been a difference in the way that bleeding events were adjudicated, but we clearly need more work on that to sort out the true significance of those differences. We will shortly have the data from another primary cardiac prophylaxis study, which is the saxophone study, which has now completed enrolment. And the abstract has been written and submitted to ISTH and will hopefully be presented in London in the middle of the year. And so that data is currently embargoed, and I can't show that to you at the minute, but keep your eye out for that, because that was a large study, 200 children involved, with a 2-to-1 randomization towards apixaban or standard of care, and treatment period for 12 months, and not only looking at bleeding and clotting outcomes, but looking at bone density and quality of life measures as well. So that will be a very useful study when we see the results in July. Moving on to the other studies that have been published. So while there are a number of other randomized controlled trials currently ongoing of DOACs in children, the only other ones that have been published are from dabigatran. Dabigatran has published 2 studies. The first publication came in 2020, and this looked at an open label, single arm prospective cohort trial in children who had already been anticoagulated for 3 months. So they had either received standard of care for the first 3 months, or they had received dabigatran or standard of care treatment in the diversity trial, which I'll come to in a second. And at the end of the 3 months, the clinical decision was that they needed ongoing treatment. They could then enter into this single-arm prospective cohort trial and go on to dabigatran for a subsequent 12 months with 1 dose titration allowed to try and get them to the plasma levels that the study was aiming for. The other study is the diversity trial, and diversity enrolled 328 children, but they only reported 267 randomly assigned children. A significant number of their patients had some protocol deviations. A significant number of the dabigatran patients permanently discontinued treatment before the end of the treatment period, and approximately 10% of the children who were receiving dabigatran discontinued the protocol because they failed to reach the target dabigatran plasma levels that the study was aiming for after the 1 dose adjustment allowed by the protocol. So these are the diagrams on the left. This is from the long-term cohort study, and you can see in the bottom blue box that there were 206 children enrolled, but over 50 of them prematurely discontinued the study. And on the right, we have the study schema for the diversity trial, where 338 patients came in, but only 267 were randomized, 177 of those to dabigatran, and about 90 to standard of care, with some further loss along the way. And so when we look at the results in the cohort study, they reported that the recurrent VTE rate was about 1% and major bleeding was 1.5%. And when we look at the diversity trial, the bleeding rates were very similar between the 2 arms of the studies. So when we think about what we've learned from all of these studies completed to date, there are some other important things to remember about the studies. All of the studies required that the children had stable oral feeds for a period of time prior to commencing being able to be randomized in the trial. And for the rivaroxaban trials, that was stable oral feeds for 10 days prior to being randomized. So therefore, a number of our patients who have got poor oral intake, especially in the infant groups, would not have been able to come into the trials. The second thing to remember is that in both of the VTE treatment trials, so that's the diversity trial and the Einstein Junior trial, the patients, once they were randomized, had to receive 5 to 9 days of heparin prior to commencing rivaroxaban for Einstein Junior, and it was 5 to 21 days of heparin or low molecular weight heparin prior to commencing dabigatran in diversity. So we have no data at all that supports that on diagnosis of a VTE, you can immediately put a child on a DOAC. The only things that have been done in the trials were to treat for at least about a week before the child could then be started on the DOAC. So you have to use a heparinoid in the initial week of treatment for any VTE in children. The other important things to note are that the trials excluded children with significant renal disease or liver disease. There were also exclusions based on the presence of other drugs, especially the azole antimycotic drugs, and that has significance for our leukemic patients who sometimes get clots, and then also some of our anticonvulsants, and that has significance for the children with cerebral synovenous thrombosis. What else don't the RCTs tell us? Well, remember that all of these studies were aimed to target a plasma exposure that was seen in the adult trials. They do not ask the question of whether or not children need the same adult drug exposure as to what the adults need. And so again, we are treating to a plasma exposure that we think is good for adults, and we have no idea whether that's the right plasma exposure for children. And that's accepted for almost all of the DOAC studies by the FDA and the EMA and other regulatory authorities. Last thing to mention that the current RCTs don't tell us is, are there any off-target effects? We know that many of the anticoagulants have off-target effects at various levels, and they are especially concerning for us, going back to my comments about we are treating children not just to get them better, but to maximize their potential for their whole future life. And as yet, we don't have any data about whether or not the DOACs have effects on any other physiological growth and development systems. Last comments and to make that the oral suspension that was used in the trials will not be available to anyone until regulatory approval has been achieved. And so that is going to mean we can't use these drugs in small children yet. We can only go down as low as the adult tablets. And again, whether or not we can actually manipulate these drugs to allow children to participate in things like contact sport was never tested in the trials. So we have a lot of work to do with ongoing registries to provide real-world data of how we actually use these drugs in our patients as we need to find them.